Welcome everybody. I'm Janine Birtwistle and I'm part of the polio team at Great Britain and Ireland, alongside Keith Paver and Derek Rothwell, who are the regional polio coordinators, Judith Diamond, who's the National Polio Plus Advocacy Advisor, and Eve Conway on the Countdown team. But we are all here to help you in whatever way you want. So without further ado, I'd like to move to the main part of the event. And I think we're extremely lucky here in Great Britain and Ireland to have not only the new Director of Polio Eradication, but the director who has just handed over the reins and who, as I understood just now, has already had his leaving party, albeit by Zoom. But that is one of the things about Zoom. We can all see each other and have time with each other that we wouldn't necessarily see face to face. So there are some advantages. So we are joined this evening by Aidan O'Leary. Aidan is the new Director of Polio Eradication. He's from Ireland, so you might recognise the accent, and he has said that he'll help us anything that we can to promote polio giving from the Irish contingency. Not just Rotarians, but governments as well. And of course, by Michel Zaffran, who is the retiring Director of Polio Eradication. So I'm going to share my screen so that you've got their presentation. And I'm going to hand it over to Aidan. I think you're going to be starting.
So, good evening, Janine, Rotarians, friends and colleagues. Many thanks for the opportunity to join with you this evening and to give you an update of where the programme is at. Just very briefly on myself, I've joined WHO for the first time on the 1st of January. So I'm very new to WHO. I'm also very new to headquarters, having spent the last 20 years working in the deep field in what our humanitarians refer to as complex protracted emergencies. So my career is kind of taking me from places like Bosnia, Gaza, Afghanistan, Pakistan, Syria, Iraq, and Yemen. So it will be a little bit of a change to work in a HQ environment for the first time. But I also are kind of ask in advance for your forbearance and understanding as I work to navigate that in a better way. I'm not new to the polio program, having worked with UNICEF for almost 3 years in Pakistan between 2015 and 2017. So at that time, as you're aware, you may be aware, or I had arrived at a time when Sirleem had described the program as a little, or as, you know, or almost a disaster. But we had seen significant progress to 2017. I do hope that I will be able to or inject that energy going forward. So in terms of the presentation today, what we would like to do is to break it into 2 parts. I will do the first couple of slides and then I'll pass to Michel, who I would like to take the opportunity to thank. He's been very, very helpful and supportive in terms of ensuring we have a smooth transition, which basically started from early November whilst I was in Yemen, and I'll have the benefit of until the end of February. So sincere thanks to Michel for that. So first thing maybe to kind of quickly touch upon, so what's new? And I think the first thing that we've seen in 2020 is the certification of Africa as a polio-free region, bringing the total of polio-free regions to 5, just 1 to go. And I think more importantly, what we've seen is the number of endemic countries are reduced from 125 to 2, which is what we're faced with today. And as part of that journey, what we've basically seen is more than 2.5 billion children protected through immunization. We've had more than 18 million, cases of polio paralysis prevented, and more than 1.5 million lives. So I think, are important to recognize how far along the journey we are. But obviously, as we look at what is left, the key thing is how do we actually get to achieving and sustaining 0? Afghanistan and Pakistan remain the key when it comes to wild polio virus transmission. And I think what we've seen is a situation from approximately 33 cases in 2018, jumping to almost 175 in 2019, and a really big expectation in 2020 that we would be able to make a significant breakthrough and inroads, which was unfortunately interrupted by the dynamics of COVID, which resulted in pauses for a 4-month period between essentially March into July, with a resumption of campaigns in an increasingly robust way from September onwards. We have seen a reduction in the number of cases recorded for 2020 to date. We have 140 in the epidemiological block. We have basically 84 in Pakistan, 56 in Afghanistan. I think the real areas of concern where we will be focusing on is the persistent transmission that's taking place in the core reservoirs of Karachi and the Quetta block. And obviously the major challenges which continue to persist in southern Afghanistan. When we look at the situation in southern Afghanistan, whether we look at wild polio virus or we look at circulating vaccine-derived polio virus, what is very, very clear is that approximately 80 to 85% of the cases are in those areas which are either inaccessible or partially accessible to the program. So the ban by the Taliban on any forms of campaigns has essentially resulted in a situation where there were approximately 3.5 million children who are unable to receive the vaccination that they require. What that has generated is an explosive outbreak of particularly circulating vaccine-derived polio virus in those southern regions. And obviously that has an impact in terms of the co-circulation of both wild polio and CVDPVs. Essentially means that our trivalent OPV continues to be a primary vaccine in the responses that are conducted. So what else is new? We clearly have a global CVDPV emergency. What we've basically seen is from 2018 through to 2020, a trebling of cases, between 2018 again to 2019, and an almost trebling of cases that are taking place in 2020. These are very much concentrated in the Afro region and in Afghanistan, Pakistan. Again, I think the critical point to note is that what we are beginning to see in 2020 is a slowing of the number of outbreaks that are being recorded. And I think most critically, we've seen a significant number of outbreaks stopped, notwithstanding the challenges that are involved with our, operating in the pandemic environment. We have a serious expectation that we will make significant further inroads into these CVDPVs during the course of 2021, as basically SIAs become, we up the game in terms of timeliness, scope, and quality of operations. So basically moving quicker, bigger, and to a higher quality than what we've been able to achieve in 2020. And I'm reasonably confident that we're going to see significant progress in that regard. What's going to help us with this outbreak response is the development of the emergency use listing of novel OPV2. And this is a vaccine that had been under development for a period of almost 10 years. And what it basically provides is improved genetic stability to decrease risks of any new outbreaks that occur. The emergency use listing was granted in late November 2020. Countries across a number of regions are working to prepare for our safe rollout. There are a broad series of criteria that they must achieve in this initial use phase. And where we basically stand at the moment, what you see on the graphic on the right-hand side are those countries that are the closest to rollout. So these are basically Nigeria and Liberia, with our Benin, Sierra Leone, and Congo very shortly behind them. We do anticipate that the first campaigns, it's not clear whether it will be either Nigeria or it will be Liberia, but we do expect these to take place in the first 1 to 2 weeks of March. And this is significant because what it basically will allow us to do is to move to the next phase of the vaccine rollout, which will take place approximately 4 to 5 months after the SAGE have had an opportunity to review all the safety data that is required to basically allow us to move to that next stage. What I think is important to note is that we have upwards of 200 million doses in the stockpile to support this outbreak response, with further replenishments planned for the latter part of this year to basically prepare for further expansion of the use of this vaccine to deal with any outbreaks that will arise during that period. What else is new? And it's clearly working in a new reality. So the Polio Oversight Board did decide during the course of 2020 that there was a requirement to use polio assets, resources, and infrastructure to basically deal with the overarching public health imperative that was the pandemic response. And that has involved everything from outbreak response preparedness, disease surveillance, contract tracing, risk communications, data management and reporting, and a whole range of supports around training and the development of guidance and operational norms. What's most important is that in its meeting in December, the POB did commit very formally to use polio-funded assets in support of countries in the critical phase of COVID-19 vaccine introduction and delivery. What you basically see in the right top-hand corner of this slide is the status of COVID vaccine rollout and introduction as of mid-February. So essentially it covers the northern half of the globe. Most of the areas of primary interest to polio, there has been no introduction. So the work that is underway continues to be very much around planning preparedness with a view to making sure that vaccines are basically effectively and efficiently delivered the moment the supply pipelines work through. So that will remain a kind of a critical area of work for 2021. In the lower part of this slide, what you basically see is an indication of the timelines for the rollout and introduction of vaccines, globally. And the two that I've highlighted is one was the introduction of inactivated polio vaccine, which was basically the subject of a WHO resolution in 2014. And what you basically see is, the period of time it essentially took from our period with a relatively high base of countries that had already introduced IPV to where it actually reached all countries. So that took a period of between 4 and 5 years. What has been basically proposed in relation to COVID vaccine is that we start from a much lower base and we need to reach a much higher number of countries in an extremely tight timeline. So again, there's a lot of work taking place at all levels, country, region, and global, to make sure that there is a fully integrated approach towards delivering on the commitments that has been made by the Polio Oversight Board. What is also new, I think, is with the COVID pandemic, is probably a new and a fresh realization, as well as a reminder of just how quickly infectious diseases spread globally. So when we speak of the situation with polio, I think it's important to recognize that polio is one such infectious disease. We've come an extraordinarily long way, but it's also important to recognize that if we don't eradicate polio, we do run the risk of up to 200,000 new cases, taking place annually within a period of 10 years. So the imperative to finish the job is very much there. And I have to say, I was extraordinarily impressed by a session I did with your colleagues in India, which basically used the opportunity of the 10-year anniversary of their last case to basically talk about the steps that needed to be taken to prevent the reemergence of polio in India. So again, very much building on what our DG has often spoken to, is that it's not over anywhere until it's over everywhere. And I think this applies as much to polio as to any other infectious disease. So what are we also working at in terms of what's new? And essentially it's the topic of integration. And I think it's the importance of recognizing that, you know, what we basically do through polio campaigns is supplementary immunization activities. When we speak about routine immunization, making sure that right across the globe that we have our basically comprehensive and equitable coverage everywhere, this is the real key towards making sure that not just do we achieve, but we actually sustain zero. And in this regard, I would kind of draw to your attention that since 2016, there have been just over 1,500 cases of circulating vaccine-derived poliovirus. 90% of those children never achieved an IPV dose. They never achieved it. So when we talk about, you know, we can basically be like the emergency services, we can close outbreaks, but if we are to prevent reemergence, we need to be really, really clear that, you know, it's not just a question of closing the outbreak. We need to make sure that our routine immunization colleagues are very much able to do the job that they have to do to essentially ensure that the gains are sustained. So I think it's a really important point. So when we talk about zero dose and missed communities, everywhere where we see these cases, these are the areas where the program is, you know, in terms of the overall immunization agenda, this is where we are the weakest. If I look or take the example of the country from which I've just come from, which is Yemen, we've had a CVDPV outbreak, and it's basically located in the Sada region in northwestern Yemen, where essentially routine immunization systems have collapsed over an extended period of time. So rebuilding that, not just closing the outbreak, is going to be really important in terms of reemergence going forward. So with under that broad umbrella of the Immunization Agenda 2030, ultimately what you will see is we will be taking steps to build in a very pragmatic, country by country approach to make sure that, you know, we are coming up with appropriate solutions to the challenges that we face. These essential immunization activities include surveillance for a range of vaccine preventable diseases, community engagement, because again, we've had these amazing social mobilizers who have really deep knowledges of communities, as well as you know, strengthened outbreak response. These are all key areas that we're going to have to do better in a much more joined up way. And then last but not least, we also have to continue with the accelerating the transition of polio essential functions and sustaining them beyond 2022. And this is making sure that, you know, within the WHO apparatus in particular, as countries move beyond the kind of at risk and vulnerable stages, these kind of our essential assets are being basically, you know, seamlessly transferred either to or to the IVB program to make sure that, as I say, we don't lose what is critical international public health infrastructure. The last thing that's new that I'd like to touch upon is the work that's underway to basically update strategy. And this is an exercise that has been underway since the middle of last year. Essentially it involves is a very hard look at all aspects of our operations, our management structures, our governance structures, to basically ensure that they're fit for purpose. And really identifying those areas of change, whether, you know, major step change or more incremental change, to make sure that we are on this critical path towards zero. So I've used the term finishing the job. So again, it's recognizing that, you know, the last mile is invariably the hardest, but what we really have to be doing is focusing on those key shifts that need to take place. The goals are essentially revolve around zero WPV and zero circulating vaccine-derived polio. In terms of the kind of key objectives, it's everything from high quality or campaign operations to strengthened community engagement, timely and sensitive surveillance, towards greater advocacy and towards much greater political will in those countries where that's required. And last but not least, the broader question of strengthened partnerships and more integrated approaches as we progress going forward. It's basically being developed following extensive consultations with countries, donors and partners, and obviously has been informed by the work of Sir Liam Donaldson and the Independent Monitoring Board, as well as the IHR Emergency Committee and a number of polio specialist bodies. So again, this is something that we hope will be finalized by the end of the first quarter. And then we really focus on the mission of basically achieving and sustaining zero. And on that note, I'll pass to Michel.
Thank you, Aidan. Next slide, please. So Aidan has presented to you the new environment, the new tools, and the new strategy that he's going to be leading the program under. But what is not new clearly in this context is the fact that Rotary's commitment will remain unwavering. We absolutely need Rotary to continue to support and lead this program. Rotary and Rotarians are the moral authority of polio eradication, whose voice, leadership, and action inspired the commitment and support of public and private partners around the world, from donor governments to heads of states to mothers on the ground civil society organizations. It's absolutely critical that Rotary continues with its efforts to support the eradication of polio. Rotary was the first to have the vision and a dream of a world free of polio. Rotarians worldwide have made themselves, have donated themselves a huge amount of money, like up to $2 billion, and they've mobilized through their advocacy more than $7 billion from donor governments. I must say, being a Frenchman, that they've mobilized money from all of the governments except from France. As a result, and I'm saying this because my district governor is on the line, as a result, more than 2.5 billion children around the world are basically protected against these diseases. Rotary in the Great Britain and Ireland has been extremely engaged in Polio Plus. More than 41,000 Rotarians in Great Britain and Ireland have actually personally contributed more than $45 million to Polio Plus. Rotarians have a long-standing and trustworthy relationship with the UK and the Irish governments, thanks to this. Polio is a key priority to these governments. The UK, in particular, is a very strong and committed partner of the program, and this continued leadership is critical now, as the UK chairs the G7 and is key to planning and preparing Commonwealth Summit. Support by Ireland was critical in tackling World Poliovirus in Nigeria in 2016 and setting the continent on its path to being declared wild polio-free, which happened just last year in August. As Rotarians continue to engage with their public sector counterparts at all levels, please thank the governments for their support and encourage them for their continued leadership and engagement in support of Polio Please. UK global leadership, key opportunity in 2021, presents key opportunities to ensure polio remains on the top of the world's agenda. Rotary, again, is leading the way, starting from its senior leadership with Rotary International Holger, calling on the Rotary network to use its influence and expertise with vaccine-preventable diseases such as polio, in also supporting the vaccine rollout of COVID vaccines. In Germany and other countries, Rotarians have launched an innovative campaign reminding people that we are fortunate to live in countries with strong access to health services, and calling on people, depending on their own personal situations, which may also, of course, be disrupted by COVID, to contribute to the extent that they can to the cost of a COVID contribute the cost of a COVID vaccine to help ensure children who have benefited from polio vaccination as a result of COVID-19 disruption can again benefit. So, you know, I was giving a presentation last week to a club, to a Rotary club in California, and basically they were donating the value of their COVID vaccination to the Polio Plus as a gesture towards the Polio Plus program. We're all anxiously awaiting the last case of polio, when polio is finally completely eradicated once and for all. But in the meantime, we need to remember that Rotary and Rotarian have achieved a lot. We have, as Aidan has already mentioned, nearly 19 million people who are walking today who would otherwise have been paralyzed. 1.5 million childhood lives have actually been saved thanks to the co-administration of vitamin A during polio campaigns. And then a network of more than 20 million volunteers, many of them actually Rotarians, have been mobilized. And this network has helped contribute support to many other disease programs. Nearly 3 billion children have been immunized, helping contribute towards a healthier world. And a healthier world is a safer, more stable, more secure world. A few years ago, the Wall Street Journal conducted an analysis of the polio eradication effort. That's several years back. But its conclusion still stands, was that for its polio eradication program, Polio Plus program, Rotary deserved, can you click please, the Nobel Peace Prize. At WHO, we certainly agree with this assessment, but first we need to achieve final success. So we cannot stop until polio is completely eradicated. And unlike with diseases such as COVID, we know that what we need to do and what we have the tools to do it. Now we have the tools for COVID, but it's going to take a long time before the disease burden diminishes. With polio, we're close to the end. We actually can do it with a very effective vaccines that we have available. So I leave you with two messages. First, I want to thank you for everything that you've done around the world to bring the world so close to polio eradication. And of course, our goal as Rotarian is to raise an additional $50 million every year towards Polio Plus, so that with the Bill and Melinda Gates Foundation, we actually contribute $150 million to the program. Please redouble your efforts and your support and engagement so that we can bring together the program to finish the job. We cannot achieve success without your continued support and leadership and advocacy with the government. You are the moral authority of polio eradication. Please use your voice, continue to speak up so that we hold governments accountable to achieving this success. Thank you very much.
Thank you very much, Michel and Aidan. And I can see that there's a lot of applause going on in the background, even if it is silent. Thank you very, very much for bringing us up to speed. There were some interesting facts there that after probably hearing more polio presentations over the last goodness knows how many years than a lot of other Rotarians I've never heard. So it's great that we're making such enormous progress. Now, before we move into questions, I would just like to personally, and on behalf of Rotary in Great Britain and Ireland, say a huge thank you to Michel. Michel, as in his role as Director of Polio Eradication, has been an amazing supporter, so willing to help Rotary. It's very much about partnerships, and partnerships are actually about people. It doesn't matter what the organisations are, it's about human connections. And Michel, and I'm sure Aidan will step into his shoes and do his job just as well, but just differently, because we are all human and we all do things differently. So Michel, I really would like to say on my own behalf and on behalf of every Rotarian across these islands and across the globe, thank you so much for everything that you've done in your term as Director of Polio Eradication at the WHO. And I'd also like to say, looking forward to working with you going forward as a Rotarian. So
absolutely. I'm leaving WHO, but I'm not leaving Rotary. And actually, I'm going to make sure that my club and my district continue to highly support the program.
Thanks very much, Michel. So we're going to be moving on to questions in a moment. Keith, I hope you've been sending some emails, some chat questions through to Keith. Do you want to give me a thumbs up as to whether you've got some or not, Keith? Yes, you have. Good. Okay. I've had a couple in advance of this evening, and I think one of them has already been answered, but I'm just going to give you the opportunity, Aidan, if there's anything else you'd like to mention. This question was from Keith Barnard-Jones, and it's about the new vaccine and is it actually in use? Keith, I know, does a lot of reading as well in the polio arena, and he hasn't been able to read a lot about it. If it has already been used, how effective is it? Is there anything else you'd like to add to what you've already said, Aidan?
Or not really. I think simply to, again, just to reiterate it, it looks as if it would be Liberia and Nigeria in early March is where the vaccine will be rolled out for the first time. I think both countries, it's great that we are having one very large country and perhaps a smaller country, because we're going to have hopefully sufficient data to meet the various different safety requirements. But I do anticipate, based on that, that during the course of the third quarter of this year, we will see a much more expanded rollout. But we do continue to encourage as many countries as possible to start the preparedness and the readiness steps now. So we do have actually really large scale use across the board, in the second half of this year.
Thanks very much, Aidan. Keith, should we have one from you now?
Yes, I've got my microphone is on. Perhaps I'll start with the very first one we received, which was from Eric Hall, who's a friend of ours. And he asked if Aidan could comment. He talked about trivalent OPV, which is being used in Afghanistan and Pakistan. If you'd like to comment a little bit more about that.
So I think just on the use of trivalent, I think where we have basically a situation where both wild poliovirus 1 and CVDPV2 is co-circulating in these contexts. What we're looking to do is to basically get as much bang from the vaccine as we possibly can. And clearly, using the trivalent gives us the best kind of prospect of achieving that. I also think it's going to be particularly important as we go forward in southern Afghanistan. So where we may have our very, very limited opportunities to access our children. So it's very, very important that we try and kind of get as much immunity across the three different types as we possibly can, or shall we say, in as short a period as we possibly can. So essentially, it just seems to be the most effective and efficient way, given the particular challenges we face with co-circulation at this time.
Thank you, Aidan. As you've mentioned Afghanistan, I just want to also put the next question, which is from Stephen Gillingham. And this is about the border between Pakistan and Afghanistan. He's asking that outside of the Friendship Gate, the border crossing there, what percentage of people are actually crossing the border that you know of, other than using that crossing?
Thank you. I think that's a really good question. And I guess the first point that I would make is to highlight that we don't treat Afghanistan and Pakistan as separate countries. We treat them as a single epidemiological block.
Yep.
And the reason that we do that is that the scale of movement is such that, if we were to basically try and just concentrate on, establishing posts at different places, we would just miss huge swathes of the population. If we look, for instance, at the transit or our vaccination component of the program in Pakistan alone, it vaccinates almost 30 million children a year. So, and if I give you, for instance, a place like Karachi, Karachi with a population of 25 to 26 million, sees massive movements of population across Pakistan and Afghanistan. And, I know from my own experience that we had tracked, for instance, one of the tribes, the Akakel, who traveled from northern Peshawar, from northern Khyber Pakhtunkhwa, from Kunduz, from Kabul, from Lagman, from Kandahar and Helmand, and they all ended up in the same area of Gidap and they do it on a seasonal basis. They don't travel through the friendship gates. They travel through a whole series of informal routes that they have used for years, for decades. And I think what's really important for us to recognize is that, a border doesn't work in that way. No. What we have to seek to do is to try and capture as many as we can while they're moving, but also to really make sure that we vaccinate them where they originated from and ultimately where they arrive. And that's ultimately what the program is doing, is basically a three-pronged push.
Thanks, Aidan. Michel, could I just ask you, not a direct question that we've had from the audience, but just talking about Afghanistan. I remember a few years ago that the thought was that Afghanistan was on the verge of being polio free. Have I remembered that incorrectly? And what has caused the change?
No, you're entirely right. Actually, if I'm not mistaken, in 2016, at least, Afghanistan did completely stop the transmission of the endemic poliovirus. They were then reinfected from importation from Pakistan, but the endemic virus was circulation was stopped. I think, but of course the future will tell us, I think that Afghanistan could indeed relatively rapidly sort of stop the circulation of the poliovirus if it had access, if the program had access to the children. And at the moment, we haven't been able to vaccinate for at least almost 2 years now in the South province. So it's, without vaccination, the minute you get the virus imported there, you have huge outbreaks, which is the case at the moment. So the density of the population in Afghanistan, is such that, interruption should be relatively feasible without the same difficulties that we're facing in Pakistan. But indeed, we need to ensure that both countries do it at the same time, all core reservoirs do it at the same time. Otherwise, those places that are cleaned out will be reinfected. This is what's happened in Pakistan. From the core reservoir now, we have sort of, unfortunately, Punjab being infected, huge circulation.
Thank you. Keith, have you got another question?
Well, I was just going to ask a question that is really relevant to what we've just been talking about, and it's about the messages we hear which are about the cooperation of the Taliban, which especially in those areas which are in the southern Afghanistan, which are, yes, low population density or lower population density, but it is critical that we get their help or support anyway. So could you comment on how relations are with the Taliban at the moment?
I will let Aidan tackle that one.
Thanks very much. So, clearly access is going to be a key issue. Afghanistan is facing a fairly tricky moment at the moment with changes of US administration and, the stance of whether we're coming or going. So there are heightened sensitivities in terms of how we navigate that space between the government of Afghanistan and the Taliban. But I also think there are opportunities. And when we look, for instance, at the proposed introduction of the COVAX facility, you may have seen that there were kind of initial signals where we could start moving from initially the bans that we face at the moment to starting with mosque-to-mosque campaigns. And I guess what we're basically going to seek to do is to draw upon every single opportunity that we have to reach the children in these areas that are restricted. So if we start with mosque to mosque and build that up, but it's important that we do it steadily or systematically, but also in a way that is very sensitive to the very real sensitivities that are operating in these areas at this point in time. But it has been done before. I think it can be done again, but I think we have to be doing it in a way that is kind of very, very clear-eyed in terms of the risks and challenges that are involved.
Thank you. I got more questions, Janine. I mean, there's a very simple.
Yeah, can I just make one point in relation to Afghanistan and Pakistan? Our May polio seminar, we haven't yet fixed the date, but the focus of that seminar will be specifically about Afghanistan and Pakistan. So I think that will be of interest to all of us, and that will be with one of your colleagues, Aidan, the Director of Polio Eradication in the Eastern Mediterranean region.
Correct. Hamid Jaffari, and I think he should be able to give you a really deep insight in terms of some of the very specific details that you're highlighting. No, I think it's a great opportunity.
Right.
Hamid is a very experienced, of course, polio eradicator. He was at the head of the program in India when India sort of was able to stop transmission. And then he came to Geneva as my predecessor and therefore Aidan's predecessor. So I think you have with Hamid presenting to you in May, a very strong sort of representation of the program.
Right. Okay, this is a quick question, and it's about temperature about the cold chain. Are the vaccines temperature dependent, and how do we manage the temperature control? I think that's a fairly quick one that one of you could answer.
Yes, so this is my baby, the cold chain. I started in this world of immunization working on cold chain. We actually have a fantastic tool on all vaccines now, which is called the vaccine vial monitor. It's a small heat sensitive temperature label which goes on each one of the labels of the vials, and it changes color over time when the vaccine vial is exposed to heat. So after a certain point, the vial has the indicator reaches a certain color, and the health worker can say, well, the vaccine cannot be used because it's been damaged by heat. But of course, all countries have over the years also established a complete cold chain with refrigerators, well-trained personnel, and insulated containers to actually transport the vaccine. But I don't think that the cold chain now is a rate limiting factor. We've got vaccines that are heat sensitive, but we've got extremely very good tools that can help us sort of reach even very remote population, in particular this vaccine vial monitor.
Well, thank you. If I may move on, I mean, I'll come back to Paul Birtwistle because as Janine's husband, he can go down the queue a bit, but I think can answer him part of the question anyway myself. Richard Cooper, who is my own district as the End Polio Now champion, is asked. You've asked about people donating the cost of their COVID-19 vaccination. What is the? I mean, the answer may be what is the cost of the COVID-19 vaccine, particularly the one that we will be using in through COVAX in other parts of the world. What would be the cost of that per dose? And really he wants to know how much he suggests we should donate. I mean, I can answer him from my district point of view. I can't happily if you donated $55, Richard. Could you say a bit about that, Michel?
Well, not really, because all countries have negotiated different prices for the vaccines. But the idea is you get a COVID vaccine shot or 2 shots in most cases. It's on average $20, $25 a dose. Some countries negotiate at much lower price, but if you're willing, depending on your ability to donate, you're willing to donate, it's good gesture, $20, $30, $40 to Polio Plus. That's since you're getting the vaccine, the COVID vaccine free of charge in most cases.
Yeah.
So that's a nice way to support global health. And
I think the point you also make is that the cost of the vaccine is not just what the manufacturer is charging, because AstraZeneca are doing it to $3 a dose at cost, but it's a lot of other bits which include its cold chain and so on. I think it's a good question. We've talked about the whole area of what we do extra apart from vaccination. So I've had a question from District 6000 in the USA, from the DGE there, and he asked what other resources are we also concentrating on as part of the global polio eradication campaigns in these areas. So it's what's the plus bit, which perhaps Michel or Aidan, I don't know which one is better at this.
Sorry, Aidan, if I could just interrupt for a second on that. On the Polio Plus, that's actually the subject of our next polio seminar, which is on March the 18th, which I'll tell you about in a minute. But Aidan, you give your answer on the plus, please.
Super. So maybe, or I think as I briefly mentioned, it's almost a country by country dynamic. So I think, if we, for instance, look at places like Afghanistan, Polio Plus could be anything from private healthcare facilities in southern Afghanistan that are able to operate, any means that allow us to kind of reach children in an appropriate way. In places like Pakistan, or particularly in the highest risk areas, the demands of communities go way beyond just polio drops. So it's everything from injections to water and sanitation systems to broader health interventions around nutrition and otherwise. And I think we are exploring elements such as that. And then when we look at particularly the situation in the African countries, what we really are trying to do is to build those core elements of, our our health services, to try and make sure that there is basically timely response on that. So the plus is really, kind of making these routine health services, routine basic services in communities at highest risk, as kind of are achievable and sustainable as we possibly can.
Basically, to give them as much of what we get for nothing, free anyway. Janine, there is one important question. I see I see you're telling me we're running out of time, and that's about vaccine hesitancy. Not here in the UK. I mean, that's a problem that we will have to deal with in a different way. But vaccine hesitancy in the tribal areas in Afghanistan and Pakistan, and how do we address that? And you've already mentioned a bit the community involvement. Perhaps you could go on a bit more about that.
Super. So I think there's a couple of aspects to it. One is, community involvement, community engagement, community ownership, and, trying to position the program in a way that we're seen as part of the solution and not part of the problem. But I also think there's a very important element that, when we're dealing with misinformation, disinformation, and rumors, the only antidote to that is correct information delivered through the correct channels. So whether that is medical, whether it's community leaders, whether it's religious leaders, what we have to basically do is continue to chip away to make sure that we're getting the right information to the right people through the right means, and really making sure that we are as responsive as we possibly can to overall needs of the communities that we seek to serve.
Yeah, I mean, it's interesting that Richard come back from my district said it's a problem here with our black and ethnic minority things. Well, you've talked about mosque to mosque working in Afghanistan. A lot of our black and ethnic minorities are in, particularly in the big cities, are in mosques and in churches. And that's where we can work in the same way. But I think that's a different question. I've come back, if I may, I'd say so, and Paul does have a chance to have an answer to his question, which was, he said, should we be concerned here in the UK and Ireland about the prediction that if we didn't continue with the campaign, if we stopped, that we'd see 200,000 cases a year within 10 years? Just to let Paul know that the latest figures from England and Wales are that the recommended level of vaccination of the IPV containing vaccine is 95%. The latest quarter 2 for 2020-21 is that at the age of 2, it's at 94% in England and Wales, and the age of 1, it's 92.5%, which perhaps I won't comment as a virologist. Perhaps you could comment on the fact that that is a risk to us here in the UK. They get fed up of me telling people that.
Yes, but I think the key is that, I mean, if you look at the modelling that was basically done, it's in these areas where you have weak routine immunisation systems.
Yeah.
And I think, the key is that for as long as we have very strong routine immunization systems, I mean, that is the primary our means of defense. And I think making sure that that's remains strong and robust remains the key way forward.
Absolutely. And it's what governments provide rather than what the supplements that we provide. Yeah.
Right.
Well, thank you very much for your help with that, Keith. And thanks again, of course, to Aidan and Michel for answering those questions. If there are any questions that are unanswered, please send them through to us, either through our emails or through the chat box now, and we will get back to you. What I would like to do is actually just give Aidan and Michel the opportunity before they go, before we finish at 8, and I am keen that we do finish on time. Is there a last minute message that you've got for us, or a last minute call to action that we haven't covered, or something that you want to re-emphasize? So Aidan, could I ask you first?
Many thanks, Janine. So I will leave you with one story and one message, if I may. So the story is around my boss, the Dr. Tedros. So when he introduces me, he does not introduce me as the Director of Polio. He introduces me as the Director of Polio Eradication. And he explained to me why he actually says that. So when he was a district health officer responding to a malaria outbreak in southern Ethiopia, he talked about, being on a team that was driving towards the compound at the center of where the outbreak was. And, when they arrived, they knocked on the door and they said, we're malaria. And the security guards said, stay away, we have so much malaria, we don't want any more. And then the driver had to explain, malaria control. And I think the point that I really want to get across is, eradication is a mindset. Bad news is good news. But what we're not interested in is containing the virus. We're interested in eradicating and eliminating the virus. And the mindset that goes with that, it brings highs and lows, but that's the key element to go forward. And then I think the second point that I would simply, again, reinforce is that, when we talk about resuming campaigns, so national campaigns in Pakistan involve, campaigns to reach nearly 40 million children under 5 across the country, with more than 300,000 frontline healthcare workers. So what kind of is very humbling for me, just as it's very humbling to be amongst you today, is the extraordinary commitment to get that job done. So I think, they haven't given up the fight. You clearly haven't given up the fight. And we see that as a really strong motivation to continue to make sure that we do get to actually zero. Michel.
Yeah, just one message, which is going to be repeating what I said at the end of my presentation. Rotary has been sort of supporting the effort, had the vision of a polio-free world, is supporting the effort through this extraordinary progress that we've seen. We now have 5 regions of the world without polio. We've eradicated 2 of the serotypes, of the 3 serotypes of the wild virus. We cannot give up now. We cannot waste all of the efforts of hundreds of thousands of people and the millions of dollars that we've mobilized, that we've donated and mobilized, by saying, let's stop now because Pakistan and Afghanistan can do it by themselves. Why should we continue to? Because if we don't continue, if we don't stop and eradicate this virus once and for all, it will come back. It will come back, and we will have wasted all of the efforts that we put in there. So let's continue to raise money, to advocate and hold our governments responsible, and to finish the job. So thank you very much.
Thank you to both of you. There's just a couple of points I'd like to leave you all to think about before I just say a couple of other bits for diary dates, etc. Is 2 points that have been raised today. One is about the Afghanistan and Pakistan. Let's not forget, this isn't about just Afghanistan and Pakistan. Over 400 million doses of vaccine to multiple times each year. Over 2 billion doses of vaccine are being delivered into the mouths of children in 40, 50 countries around the world. So we have still got to keep that up. And if we don't, we've been told what the potential situation will be. It is still an enormous cost saving, but at the end of the day, this is about people and people's lives, for them, their own life, their family, their community, etc. And the other thing that I want to highlight is something, Keith has actually put it in the chat column as well. It's not just about the people in Afghanistan and Pakistan or other parts of the world where there are issues with polio eradication. It's about people in Great Britain and Ireland who have got family or connections or have travelled on holiday or whatever. We each, every single Rotarian, whether you've got the ability in the current circumstances to put your own hand in your pocket to give money or to raise money, you have got a voice. So whether it's giving money, raising money, or using your voice, please help us, because it is only by all of us, every single one of us working together, that we will reach those 2 words that Aidan said, and that's the polio eradication. Thank you all so much for being with us this evening. Dates for your diary, as I said before, 18th of March, our next polio seminar. That's a Thursday evening, 7 o'clock till 8 again. And that's Polio Plus, so much more than just polio. And that's with our very own Judith Diamond, who's our National Polio Plus Advocacy Advisor, and so much more, and myself. So we'll be just sharing some of the incredible things that the polio programme does beyond eradicating polio. And then in April, the date yet to be fixed, but keep it in your mind, that will be focused on the circulating vaccine-derived polio. And our speaker for that will be Dr. Zubair Wadoud, who some of you will have heard in one of our talks last year. Again, key member at WHO, fantastic speaker, really looking forward to that one. And at some point in May, Afghanistan and Pakistan. So those are the next 3 polio seminars. So thank you all very, very much for everything that you are doing. Please, when the link comes out to the YouTube recording, encourage your clubs to watch it, encourage your friends and family to watch it, and encourage them to help. And don't forget Rotary's birthday, Purple for Polio Tea Party, 23rd of February next week, 4 o'clock till 5. Let's have a bit of fun and celebrate. So I hope you're all going to be able to join us for that.
Yeah,
so thank you all.
Yeah, don't leave Janine on her own on next Tuesday.
I'm not. It's being fronted by Connie Huck and Anne Waffler-Strike, 2 of our Rotary Polio ambassadors. So definitely not me. I'm just in the back room doing some of the recordings, etc. So thank you all very, very much, and I hope to see you all again on the 18th of March. Bye bye.
Thank you very much. Take care. Much appreciated.
Bye, Aidan. Bye, Michelle.
Take care.
Enjoy your retirement, Michelle.